Hello, friends. Today we are going to discuss the 2021 guidelines of acute heart failure. So, the definition of the heart failure is not a single pathological diagnosis, but a clinical syndrome consisting of cardinal symptoms, that is, breathing difficulty, ankle swelling, fatigue, that may be accompanied by the signs such as elevated jugular venous pressure, pulmonary crackles, and peripheral edema. It is due to structural and functional abnormality of the heart that results in the elevated intracardiac pressure and inadequate cardiac output at rest and during exercise. So traditionally, heart failure has been divided into the distinct phenotype based on the measurement of left ventricular ejection fraction. So according to this, the heart failure is divided into three types: heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. So for heart failure with reduced ejection fraction, the ejection fraction should be less than 40% plus signs and symptoms of heart failure should be present. Heart failure with mildly reduced ejection fraction, the ejection fraction should be 41 to 49% with signs and symptoms of the heart failure. And the heart failure with preserved ejection fraction, the ejection fraction should be more than 50% with signs and symptoms of the heart failure. The objective evidence of cardiac and structural and functional abnormalities consistent with the presence of LV diastolic dysfunction, raised LV feeling pressure, including raised natriuretic peptide. Now, right ventricular dysfunction. Heart failure can also be the result of right ventricular dysfunction. RV mechanics and function are altered in the setting of either pressure volume overload. Although the main etiology of the chronic right ventricular failure is LV dysfunction induced pulmonary hypertension, there are a number of other causes of RV dysfunction like MI, arrhythmogenic right ventricular cardiomyopathy, and valve disease. The diagnosis is determined by the quantitative assessment of the global RV function, most commonly by the echocardiography using at least one of the following measurements, like fractional area change, tricuspid annular plane systolic excursion, Doppler tissue imaging derived systolic velocity of the tricuspid annulus. The other common terminology used in heart failure is usually divided into two presentations, that is chronic heart failure and acute heart failure. Chronic heart failure describes those who have the established diagnosis of heart failure or who have more gradual onset of symptoms. If chronic heart failure deteriorates either suddenly or slowly, the episode may be described as decompensated heart failure. This can result in hospital admission or treatment with intravenous diuretic in outpatient setting. Some individuals with the heart failure may recover completely, for example, which due to alcoholic-induced cardiomyopathy, viral myocarditis, Takotsubo syndrome, peripartum cardiomyopathy, and tachycardiomyopathy. Other patients with LV systolic dysfunction may show substantial or even complete recovery of LV systolic function after receiving drug and device therapy. So this is the NYHA classification. Class 1, no limitation of physical activity. Ordinal physical activity does not cause undue breathing difficulty, fatigue, and palpitation. Class 2 is slight limitation of physical activity. That means the patient will be comfortable at rest, but ordinal physical activity results in undue breathing difficulty, fatigue, and palpitation. Class 3 is the marked limitation of the physical activity, and class 4 is unable to carry any physical activity without discomfort. So the prognosis of the patient with the heart failure had improved considerably since the publication of the first treatment trial a few decades ago. However, it remains poor and the quality of life is also markedly reduced. The improvement in the prognosis has been confined to those with heart failure with reduced ejection fraction. Now, regarding chronic heart failure, the diagnosis of chronic heart failure requires the presence of symptoms and signs of heart failure in the objective evidence of cardiac dysfunction. The typical symptoms include breathing difficulty, fatigue, ankle swelling. The symptoms and signs lack the sufficient accuracy to be used alone to make the diagnosis of heart failure. The diagnosis of chronic heart failure is made more likely in patients with history of MI, arterial hypertension, chronic artery disease, diabetes mellitus, alcohol misuse, chronic kidney disease, cardiotoxic chemotherapy, and in those with the family history of cardiomyopathy or sudden death. So signs and symptoms. Symptoms are typical symptoms include breathing difficulty, orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigue, tiredness, increased time to recover after exercise, and ankle swelling. And signs will be elevated JVP, hepatojugular reflux, third heart sound, laterally displaced apical impulse. Now the less typical signs will be nocturnal cough, wheezing, blotting, blotted feeling, loss of appetite, confusion, depression, palpitation, dizziness, syncope, bendopnea. And less specific will be weight gain, weight loss, tissue wasting, cardiac murmur, peripheral edema, pulmonary crepitation, pleural effusion, tachycardia, irregular pulse, tachypnea, kind stroke respiration, hepatomegaly, ascites, cold extremities, oliguria, and narrow pulse pressure. The following diagnostic tests are recommended for the assessment of the patient with suspected chronic heart failure, like ECG. Normal ECG makes the diagnosis of heart failure unlikely. The ECG may reveal the abnormalities such as atrial fibrillation, Q wave, left ventricular hypertrophy, widened QRS that increase the likelihood of diagnosis of heart failure and may also guide the therapy. Measurement of natriuretic peptide are recommended if available. A plasma concentration of the BN. Uh, and NT-proBNP levels less than 125 or mid-regional pro-atrial natriuretic peptide less than 40 makes the diagnosis of heart failure unlikely. Basic investigations such as serum urea, electrolyte, creatinine, full blood count, liver thyroid function test are recommended to differentiate heart failure from the other condition, to provide prognostic information and to guide potential therapy. Echocardiography is recommended as the key investigation for assessment of the cardiac function, as well as the determination of left ventricular ejection fraction. Echocardiography also provides information on other parameters such as chamber size, eccentric and concentric LVH, regional wall motion abnormalities, RV function, pulmonary hypertension, valvular function, and marker of diastolic function. Chest X-ray is recommended to investigate the other potential cause of breathing difficulty. It also provides supportive evidence of heart failure, like pulmonary congestion and cardiomegaly. So, in the summary, the recommended diagnostic test in all patients according to guidelines in suspected patient with the chronic heart failure. So, recommendations are pro-BNP. It has a class 1 recommendation level of evidence B, then pelvic ECG, transthoracic echocardiography, chest radiography, routine blood test for comorbidities including full blood count, urea, electrolytes, thyroid function, fasting glucose, HbA1c, lipid, iron status, all this investigation as a class of recommendation 1 level of evidence C. Now the natriuretic peptide, plasma concentration of natriuretic peptide are recommended as the initial diagnostic test in patient with the symptoms suggestive of heart failure to rule out diagnosis. Elevated concentrations support the diagnosis of heart failure, are useful for prognostication and may guide further cardiac investigation. However, it should be noted that there are many causes of elevated natriuretic peptide, both cardiovascular and non-cardiovascular, might reduce their diagnostic accuracy. These causes include atrial fibrillation, increased age, acute and chronic kidney disease. Conversely, natriuretic peptide concentration may be disproportionately low in obese patients. So used in acute setting, the diagnostic value of natriuretic peptide, in addition to signs, symptom, and other diagnostic tests such as ECG, has been assessed in several studies in primary care setting. The aim of these studies was to either exclude or establish diagnosis of heart failure. The upper limit of normal in non-acute setting is 35 for pro-BNP and 125 for anti-pro-BNP. So negative predictive value for natriuretic peptide concentration below this threshold ranging from 0.94 to 0.98. Concentration below less than 40 can be used to rule out heart failure. Causes of elevated concentration of natriuretic peptide. Cardiac causes are heart failure, ECS, pulmonary embolism, myocarditis, left ventricular hypertrophy, hypertrophic and destructive cardiomyopathy, valvular heart disease, congenital heart disease, atrial and ventricular tachyarrhythmias, heart contusion, cardioversion, ICD shock, surgical procedures involving the heart and pulmonary hypertension. Non-cardiac causes are advanced age, ischemic stroke, subarachnoid hemorrhage, renal dysfunction, liver dysfunction, paraneoplastic syndrome, COPD, severe infection, severe burn, anemia, severe metabolic and hormonal abnormalities. Then diagnostic algorithm for heart failure. Suspected heart failure, the risk factors, symptoms and signs, and abnormal ECG. So if you're suspecting failure, we need to assess the risk factor. We need to ask for the signs, symptoms, and we need to take the ECG. And then we will send the cardiac markers like NT-proBNP and PNP. So if it is elevated, um, so uh, if heart failure is strongly suspected, and if NT-proBNP is not and if the NT-proBNP is not available, then we can go for echo, and we need to see any abnormal findings are there or not. Meanwhile, if NT-proBNP is normal, then the heart failure is unlikely, and if it is unavailable, then the alternative diagnostic modality that we can adopt is echocardiography, and we need to see any abnormal findings are there on echocardiography or not. In the heart failure, confined defined heart failure phenotypes on the left ventricular ejection fraction measurement. So based on the ejection fraction, the heart failure is divided into the three types. Heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. For heart failure with reduced ejection fraction is less than 40. For mildly reduced ejection fraction, it is 41 to 49. And for preserved ejection fraction, it is more than 50%. Now, the investigation to determine the underlying etiology of the chronic heart failure. Exercise and pharmacological stress echocardiography may be used for assessment of inducible ischemia in those who are considered suitable for coronary revascularization. In patients with heart failure with preserved ejection fraction, valve disease, and unexplained dyspnea, cardiography might help to clarify the diagnosis. Then cardiac magnetic resonance imaging with late gadolinium enhancement, T1 mapping, and extracellular volume will identify the myocardial fibrosis and scar, which are typically subendocardial for patients with ischemic heart disease, in contrast to the mid-wall scar typical of dilated cardiomyopathy. In addition, cardiac magnetic resonance allow the myocardial characterization, for example, myocarditis, amyloidosis, sarcoidosis, Chagas disease, Fabry disease, LV non-compaction CMP, hematochromatosis, and arrhythmogenic cardiomyopathy. Computed tomography coronary angiography may be considered in patients with low to intermediate pretest probability of the CAD and those with equivocal and non-invasive stress test in order to exclude the diagnosis of the CAD. Single photon emission, that is SPECT, can be used to assess the myocardial ischemia and viability, myocardial inflammation, and the infiltration. Then scintigraphy with the technetium label biophosphate had shown high sensitivity and specificity for imaging cardiac transthyretin amyloid. So coronary angiography is recommended in patients with heart failure who have angina pectoris or anginal equivalent despite pharmacological therapy in order to establish diagnosis of CAD and its severity. So coronary angiography may also be considered in patients with heart failure with reduced ejection fraction who have intermediate or high pretest probability of CAD and who are considered potentially suitable for coronary revascularization. So these are the recommendations for specialized diagnostic tests for selected patients with chronic heart failure to detect reversible and treated cause of heart failure, like cardiac magnetic resonance. So this CMR is recommended for assessment of myocardial structure and function in those with a poor electrocardiogram acoustic window. It has a class of recommendation 1 level of evidence. CMR is recommended for characterization of the myocardial tissue in suspected infiltrative disease, Fabry's disease, and inflammatory disease. CMR with the LGE should be considered in the dilated cardiomyopathy to distinguish between ischemic and the non-ischemic myocardial damage. It has class of recommendation 2A, level of evidence C. Invasive coronary angiography. Invasive coronary angiography is recommended in patients with angina despite pharmacological therapy and symptomatic arrhythmias. It has class of recommendation 1, level of evidence B. Invasive coronary angiography may be considered in patient with heart failure with reduced ejection fraction, uh, with intermediate to high pretest probability of coronary angiography and presence of ischemia and non-invasive stress test. Now, non-invasive testing, a CT angio should be considered in patients with low to intermediate pretest probability of CAD or those with equivocal non-invasive stress test in order to rule out coronary artery stenosis. Non-invasive stress imaging, that is CMR, stress cardiography, SPECT, and PET, may be considered for assessment of myocardial ischemia and viability in patients with coronary artery disease who are considered suitable for coronary revascularization. This statement has a class of recommendation 2B, level of evidence B. Exercise testing may be considered to detect reversible myocardial ischemia and investigate the cause of dyspnea. This statement has class of recommendation 2B, level of evidence C. Cardiopulmonary exercise testing is recommended as a part of evaluation for heart transplant and mechanical circulatory devices. Cardiopulmonary exercise testing should be considered to optimize prescription of exercise testing. Cardiopulmonary exercise testing should be considered to identify cause of unexplained dyspnea and exercise intolerance. Right heart catheterization is recommended in patients with heart failure being evaluated for heart transplantation and MCS. It has a class of recommendation 1, level of evidence C. Right heart catheterization should be considered in patients where heart failure is thought to be due to constrictive pericarditis, restrictive cardiomyopathy, congenital heart disease, and high output state. Class of recommendation 2A, level of evidence C. Right heart catheterization should be considered in patients with probable pulmonary hypertension assessed by echo in order to confirm diagnosis and assess its reversibility before correction of valve and structural heart disease. Class of recommendation 2A, level of evidence C. Right heart catheterization may be considered in selected patients with heart failure with preserved ejection fraction to confirm the diagnosis. Now, the endomyocardial biopsy should be considered in patients with rapidly progressive heart failure despite standard therapy when there is probability of specific diagnosis which can be confirmed only in myocardial sample. Class of recommendation 2A, level of evidence. Now, causes of heart failure. Causes of heart failure are like coronary artery disease, hypertension, then valvular diseases, arrhythmias, cardiomyopathy, congenital heart disease. So if there is a coronary artery disease, then the specific investigations are like invasive coronary angiography, CT coronary angiography, and the imaging stress test. In case of hypertension, we need to do the 24-hour ambulatory BP, plasma metanephrine, renal artery imaging. In case of valvular disease, echo, transesophageal, and stress test. Arrhythmias, ambulatory ECG recording. Then cardiomyopathy, CMR genetic testing, uh, angiography, and trace element toxicology should be needed. Then in case of infective pathologies, include viral myocarditis, Chagas disease, HIV, and Lyme disease. Drug-induced include anthracycline, trastuzumab, vascular endothelial growth factor inhibitor, immune checkpoint inhibitor, protease inhibitor. Infiltrative cause include amyloid, sarcoidosis, neoplastic. And the specific investigation that we need to observe is serum electrophoresis, serum free light chain based on protein and bone scintigraphy. Storage disorders like hemochromatosis, Fabry disease, glycogen storage disorder. Endomyocardial disease like radiotherapy, endomyocardial fibrosis, eosinophilia, and carcinoma. Pericardial diseases like calcification and infiltrate. Metabolic disorders are endocrine disorder, nutritional disease, and autoimmune disease. Neuromuscular disease include Friedreich's ataxia and muscular atrophy. Thank you, guys.